Hello, I'm Nicholas Tedesco D.O, Co-Associate Program Director of Good Samaritan Regional Medical Center's Orthopedic Surgery Residency Program. Today I'm going to talk about total knee arthroplasty complications as part of our ongoing lecture series to supplement our in-classroom case-based learning. I have the same disclosure that I always do in that I own stock in RomTech, a small orthopedic DME company that has nothing to do with this talk or any of my talks posted online or our in-classroom lectures. So in terms of total knee arthroplasty complications, there are obviously innumerable, both perioperatively and long-term, and so we'll start off with wound complications, because this is one of the most common things that we will all clinically see. There are obviously many risk factors for this particular group of complications, and it includes everything from aseptic dehiscence to superficial infections all the way to deep infections. The risk factors for these typically are type 2 diabetes mellitus, peripheral vascular disease, rheumatoid arthritis, certain medications, particularly stimulants that can constrict blood flow, tobacco use and its associated nicotine derivatives, poor nutritional status, an albumin less than 3.5 grams per deciliter, which is a marker of poor nutritional status, total lymphocyte count less than 1,500 per microliter, again a nutritional status marker, perioperative anemia, and obesity. So in terms of wound complications, there are local factors, including the presence of a previous incision. Skin bridges should be about 5 to 6 centimeters, although this is some rather old data. Newer data suggests that you just need to be within the dermatomal distribution of a specific blood supply. As long as you maintain different dermal distributions, you can be as close as you want, because you won't disrupt the blood supply of neighboring dermatomes. You want to avoid crossing previous skin incisions at an angle less than 60 degrees because the acute point that it makes can be a relatively devascularized zone, so you try to want to make as close to right angles as possible to previous incisions. And you want to use the most lateral incision possible, just in terms of getting your exposure and improving patellar tracking and making sure that everything can kind of come together that way. Additionally, the more medial you make your incision, the more likely you are to end up with a saphenous neuritis or some similar problem like neuroma. A knee deformity, especially if you have significant correction to do or soft tissue releases, that can complicate wound issues and increase marginal necrosis, again also because of disruption of the deep blood supply that's coming up superficial to feed the skin. The presence of skin adhesions or a significant scar from previous, that will obviously increase subcutaneous dissection. It may put you in the wrong layer where you're through the cutaneous blood supply rather than a full thickness fasciocutaneous flap, and a lot of other issues can arise. And then obviously poor local blood supply. So if you have poor blood flow, then you're going to have poor healing. In terms of technique for the surgery, you do want to avoid large subcutaneous skin flaps or not preserving the subcutaneous fat layer. So this is what we just alluded to in terms of a full thickness fasciocutaneous flap. So all the way through the skin, the subcutaneous fat, and the investing muscular fascia over the top of the extensor mechanism before you start to undermine. You want to undermine just off the medial and lateral borders of the patella without going excessively further to prevent, again, a relatively devascularized zone of skin and marginal necrosis. Postoperatively, a hematoma can exert a compression force from inside the knee that can tamponade blood supply and flexion of the knee greater than 40 degrees for the first 3 to 4 days. Why that may be a problem is because if you end up with a severe valgus knee deformity and they wake up with a peroneal nerve palsy, you have to put the knee in flexion to help take some pressure off of that, and keeping the knee there can constrict blood flow, particularly to the anterior skin flaps, because as you go into flexion, you increase the tension anteriorly and again tamponade off blood supply. Treatment of wound complications includes both non-operative and operative techniques. Non-operative include local wound care, such as wet to dry dressings or application of a wound vac, as well as antibiotics if there's any concern for colonization or infection. This is indicated for small and superficial wounds and patients who are not good surgical candidates. Typically what I do in the clinic is I will probe the wound if there's dehiscence with a sterile Q-tip soaked in hydrogen peroxide, and if it penetrates deep to fascia, then you have a deep infection and a complete communication with the prosthesis in the outside world, which is an indication for surgery. As long as it does not penetrate deep to fascia, you can try and manage it superficially with these techniques. When a patient meets an operative indication, you want to perform an extensive debridement with recoverage with or without a rotational flap, which includes the medial gastrocnemius and a split thickness skin graft from the ipsilateral thigh if there's significant necrosis or dehiscence that can't be reapproximated without low tension. This is usually also indicated for full thickness necrosis, not just marginal necrosis. Again, in terms of the gastrocnemius flap, especially around the knee, you want to use a medial gastrocnemius flap because its vascular pedicle is proximal and it's from the medial sural artery. This is great for anteromedial defects. The lateral gastrocnemius rotational flap is pedicled distally, and so usually you'll release the medial flap off of the Achilles tendon and wrap it around. With the lateral gastroc, you'll release it off of the femur and wrap it around, and so it's much better for distal and lateral defects, particularly as you extend down towards the tibial shaft. This is fed by the lateral sural artery. Here's an example of a clinical image of harvesting that medial gastrocnemius flap. So you take it off of the Achilles tendon distally, you wrap it over the skin defect anteriorly. Usually you'll have to remove its investing fascia and aponeurosis in order to get it to spread and fan out wide enough to cover these defects, and then you'll take a split thickness skin graft and go back over the top of that to cover that defect. Next, we're going to briefly talk about infection. We won't delve into this in significant detail because there's a whole separate lecture on periprosthetic infection that we'll cover in the formal classroom setting because this is such a large topic, but overall incidence in total knee arthroplasty is about 1 to 2%, up to 5 to 6% in revision surgery. Many risk factors for these, all pretty obvious and related to wound healing issues once again. So immunosuppression, obesity, prior surgery, diabetes mellitus, particularly a hemoglobin A1C above 8, inflammatory arthritis like rheumatic disease or systemic lupus, smoking or tobacco use or even nicotine supplementation, as well as poor oral hygiene because of the constant bacterial load in the bloodstream. Antibiotics and impregnated cement can decrease the risk of deep infection in at-risk patient. However, data does not currently support routine use of this in all total knee arthroplasties. So if you're going to cement a knee replacement and you have a patient with significant risk factors, you may want to consider a pre-mixed antibiotic cement, but in most routine patients, this is not necessary. In terms of prevention of infection, you want to screen with MRSA colonization from the nares and treat if positive. You also want to stop DMARDs 4 to 6 weeks prior to surgery and continue cessation of them 4 to 6 weeks after surgery because there are so many new ones of these that continue to come out. Close conversation with the patient's rheumatologist is usually indicated to help coordinate all of this. Perioperatively, you want to try and administer antibiotics 30 minutes before incision to make sure that they're flowing through the bloodstream before a tourniquet is inflated. For postoperative antibiotics, you want to continue this for a total of 24 hours. Studies do not support longer than this and actually show that infection rates may be higher as you select for bugs that are resistant to the antibiotics that you're using. Laminar airflow systems in the operating room, as well as limiting operating room traffic, is key to preventing intraoperative contamination of the open wound or implants. Preoperatively, chlorhexidine baths have been shown to decrease the risk of infection as well as clipping surgical site hair. Intraoperatively, you want to minimize surgical time as infection is associated with longer surgical times. Chlorhexidine irrigate or the Iricept solution and dilute providone iodine soaks have been studied extensively. The literature is relatively mixed on the utility of these, but again may be useful in high-risk patients. Postoperatively, you do want to consider antibiotics prior to dental work. The AAOS and ADA recommends for a minimum of 1 year after surgery, and they recommend usually waiting at least 3 to 6 months postoperatively before performing any dental work. In terms of use of Ioban as well as the hoods or moon suits, these have actually been shown to potentially increase the risk of infection as opposed to decrease how they are expected to do. Sealing off drapes with Ioban around the edges has been shown to improve infection rates. However, the use of Ioban over the entire surgical field has been shown to create something called a greenhouse effect, where as the hot light shine on the loosened ioban, it will actually start to heat up the immediately adjacent skin and the fluid that is within all the pores in our skin, creating almost like a nice steamy hot greenhouse, which then allows any bacteria potentially buried deep within the pores that were not gotten by your surgical prep to multiply faster and contaminate the surgical site. This has never been shown or affiliated clinically to increase infection rates, but that's the basic science behind what could potentially do that. In terms of the hoods, both single and dual fan systems have been trialed, and they've actually shown that either way they do increase the bacterial load onto the surgical field, probably by blowing things around, and by the fact that the head is probably still not completely sterile without our knowledge, and we continue to touch that mask over and over during surgery, so you may contaminate things. Again, it's not been clinically shown to actually increase infection, but there are some basic science studies that suggest that it could. Again, in terms of infection, evaluation includes laboratory values, CRP, ESR, and WBC, an aspiration of the knee joint, as well as imaging, including 3-phase bone scan. The aspirate, you want to look for a WBC count greater than 1,100 cells per milliliter, as well as greater than 64% PMNs. A CBC may show an elevated white count, particularly in chronic infection. X-rays may show a periosteal reaction, osteolysis, or even frank implant loosening. And a 3-phase bone scan is indicated when infection is suspected but cannot be confirmed with all of these testing. It is very sensitive but not particularly specific to infection in terms of abnormalities, but a 3-phase bone scan typically will be abnormal on all 3 phases in infection, whereas only abnormal on the bone phase and aseptic loosening if osteolysis is noted on the imaging. CRP is more reliable long after surgery for detecting infection as opposed to ESR because it returns to normal in a much quicker manner. So there's a 50% higher peak after total knee arthroplasty compared with total hip arthroplasty. This peak occurs in both procedures within 3 days of surgery and returns to normal within 3 weeks, whereas the ESR takes about a week to 10 days to elevate and stays elevated for about 3 months. Serum IL-6 level has been found to be a reliable indicator of infection affecting hip or knee arthroplasty. Synovusure, or the alpha defensin on aspirate, is very reliable for detecting infection. However, it is also elevated in the presence of a severe rheumatoid flare, so if they have a severe reactive synovitis, this can cloud the picture with the alpha defensin. Serum D dimer is very sensitive for infection, as well as a leukocyte esterase urine dipstick that you can use in the clinic on your aspirate. And fluid viscosity analysis will show a significantly decreased viscosity in the presence of infection, as the infection is eating all of the proteins from the fluid that normally would make it very thick and viscous. Acute infections are usually defined as within 3 weeks of surgery, but some authors say within 6 weeks. It's confined to the joint space with no significant invasion into the prosthetic bone interface and no biofilm production, mainly because it's so hyperacute. It hasn't had time to do all that. Chronic infections are greater than 3 to 6 weeks from surgery at any point. Typically, that gives bacteria enough time to create a biofilm and infiltrate all of the surfaces. There's no good method that's ever been shown to reliably and safely completely remove biofilm once present. Acute hematogenous spread is defined as an infection usually after a long-lasting implant has been in there, and it involves symptoms less than 3 days to less than 4 weeks, depending on the author that's writing the paper. As you can imagine, then, the literature is very heterogeneous with regards to this, and similar outcomes are seen with 1 versus 2 stage revisions, both about 60 to 70% successful in terms of eradicating the infection. Chronic hematogenous is when there's at least greater than 4 weeks of symptoms, but again, many authors say greater than 3 days of symptoms. And again, the big difference is acute may be that it just got there, it hasn't had time to infiltrate all the surfaces, hasn't had time to create and set up that biofilm, and that's why the treatment may be less aggressive that could still produce good results, whereas chronic hematogenous, there's plenty of time for all of that, and typically you need aggressive surgical debridement and a 2-stage revision to fully eradicate this infection. Treatment non-operative is chronic suppressive antibiotic therapy, which is indicated for those unfit for surgery, or revision surgery would be extraordinary, or they simply are unwilling to undergo these procedures given the gravity of a 1 or 2 stage procedure. Operative is polyethylene exchange with IV antibiotics for 6 weeks for acute infections or acute hematogenous infections. 1 stage replacement with IV antibiotics for 6 weeks is gaining speed in terms of these acute infections as well as acute hematogenous infections. Usually in a healthy patient with healthy tissues and no sinus tract is when this is the most successful, especially when it's also a low virulence organism like a Peptostreptococcus as opposed to a Staphylococcus aureus. And again, you want to use antibiotic impregnated cement to give yourself every opportunity of eradicating this infection when you re-cement in a new implant. 2-stage revision is the gold standard for chronic infections or 1-stage failures. Prosthetic explant with surgical debridement is the first stage. Then you do an antibiotic spacer with IV antibiotics for 6 weeks. Can be static or articulating, with articulating showing better range of motion than the static. And then reimplantation is the second stage. You need to have normal cultures 2 weeks minimum after stopping antibiotics, but the amount of holiday off of antibiotics has not been shown to change infection rates. And again, at the time of reimplantation, even with all negative testing preoperatively, you do want to send tissue for frozen section intraoperatively just in case it was missed. And if that demonstrates infection again, then you talk about a repeat antibiotic spacer versus amputation versus placement of a new implant followed by chronic suppressive antibiotics. Again, a lot of this depends on patients' goals, desires, and medical status. The next big complication is DVT and PE. The prevalence of DVT after total knee arthroplasty without prophylaxis is anywhere from 40 to 84%, but a lot of this is very old data from the 80s and 90s. Current data shows that we have done a much better job with this, probably mostly due to our early mobilization protocols as well as better selection of medically appropriate patients and risk mitigation preoperatively, to where we've gotten these incidences down much, much lower. There's a 2 to 3 times higher rate of DVT after total knee versus total hip, and it carries with it a mortality rate of up to 2% of patients that have a symptomatic DVT or PE. Proximal thrombi in the popliteal vein and above have a greater risk of PE than in the calf. These occur in anywhere from 9 to 20% of patients when you routinely ultrasound them. However, there's no current literature in support of routine ultrasound for all patients postoperatively, only when symptoms exist. Physical exam will reveal pain and swelling, usually in the region and distal to it of the thrombus. Homan sign may be positive, but it's not very specific and not all that helpful, especially in the acute postoperative phase when everything in that leg seems to hurt these patients. And imaging, venography is technically the gold standard, but any more venous duplex ultrasound is very sensitive and specific and much cheaper and less invasive. And so this has become the standard of care going forward when index of suspicion is there for a DVT. In terms of prophylaxis, you can do non-pharmaceutical agents, so compressive stockings, although these haven't been shown to actually decrease the risk of DVT. Sequential compression devices, these do decrease venous compliance and stasis, increase venous return and endothelial-derived fibrinolysis, and do decrease the risk of DVT. Obviously, early and frequent ambulation postoperatively, as well as ankle pumps and in-bed exercises and early mobilization are the most important things for prevention of DVT, as it gets the blood flowing right away and prevents clotting. In terms of pharmaceutical agents, there are multiple used. It depends on regional differences or your institution or the particular attending that you're working with. There's no literature in absolute support of one method over another, but essentially you have aspirin, low molecular weight heparin, and Coumadin as the most commonly used things throughout the nation. I'll let you pause and read these slides for this particular information, but essentially they all seem to be good, and we are starting to lean more and more towards less and less prophylaxis given the bleeding complications and the expense of some of these products, and especially given that we've significantly lowered the DVT and PE rates. So anymore, the standard is largely gaining speed in terms of 81 milligrams of aspirin twice a day, and even some studies are now suggesting once a day and only for 30 days postoperatively, compared to 6 weeks, which is what has routinely been done for many years. These are additional agents, again, very commonly used, especially in high-risk patients or as standards for some particular attendings. Again, these are their mechanisms of actions that could be on your test, so it is worthwhile pausing this and studying these and creating a table for yourself that helps you remember them. But again, they're all aimed at prevention of DVT and PE, And then these are the bigger guns that can also be used to treat symptomatic DVT and PE if it occurs. Vascular injury is another complication. The incidence of this is very, very low, fractions of 1%, but it does happen. Risk factors are revision surgery, usually due to tight exposure as well as extensive scarring and abnormal anatomy, as well as severe peripheral vascular disease, particularly arteriosclerosis, where you can actually fracture a vessel just by manipulation of it because there's so much calcium within adventitia. Causes include direct laceration, usually from dissection in the posterior compartment or from the saw blade when cutting the tibia, and then blunt trauma, usually that posterior retractor placement as you try to lever that tibia forward. And you can see these images on the right side of the screen are a cadaver study where they have a posterior retractor in there, and you can see just how close that comes to the popliteal vessel. So you can imagine as you slide that in there, you could easily hit them. And then if you're not careful managing that knee after you've made your bone cuts during the surgery, you can significantly tent and even rupture the vessel as you're moving the knee out or extending it if it hyperextends like that, which is what's shown in the lower view. So blunt trauma, stretching, laceration, all kinds of things can create this problem during surgery. Anatomy is that the popliteal vessels are a continuation of the superficial femoral artery. They lie posterior to the posterior horn of the lateral meniscus, directly behind the posterior capsule. They're anchored to the soleus tendon at the soleal arch as it exits the popliteal fossa. Presentation intraoperatively usually will have brisk bleeding or loss of pulses distally, especially if you're using a tourniquet and you let the tourniquet down and all of a sudden there's significant blood formation and even pulsatile blood within the wound coming from centrally and posteriorly. And then post-operatively, it will present as ischemia, sensory changes, loss of pulses, or skin mottling or coolness. Treatment intraoperatively is immediate vascular surgery consultation. Imaging, including an angiogram or a Doppler, may be helpful to determine the site and location. Post-operatively, if they have any of those things we just talked about and you're suspicious for an arterial injury, then you'll want to get a CT angiogram with lower extremity runoff and then an urgent vascular surgery consult. So you can see on the right lower image here, that's what that is, where you can see the dye flowing in the superficial femoral artery, becoming the popliteal artery, and then all of a sudden no flow distal to the knee. And in the images above, those are intraoperative angiograms using fluoroscopy, again seeing that blush coming out of the popliteal vessel with no flow distal to it, indicating the site of damage. Complications include compartment syndrome, need for amputation as a life-saving measure, or even mortality if enough blood loss occurs. So this is a very serious complication when it does occur. And if it does occur, whether an arterial repair is required or not by vascular surgery, you usually want to admit these patients to the ICU for very close neurovascular monitoring, not only to make sure that there's not a rupture of a pseudoaneurysm or something that occurs later, but also for compartment syndrome monitoring. Nerve palsy is another very rare complication with the incidence around 1%. Increased risk for peroneal nerve palsy when there's a significant preoperative valgus deformity or flexion contracture, if there's an extended tourniquet time greater than 120 minutes with compression on the leg and the nerves, if there's postoperative use of epidural analgesia, that may keep those nerves shut off for quite a while. And if they have a preoperative diagnosis of peripheral or central neuropathy, there is a higher risk of worse palsy postoperatively, probably due to hypersensitivity of the nerves already in the presence of damage. Treatment: if a peroneal nerve injury is suspected, then the leg should be placed in flexion and compressive dressing should be removed. This is some of the stuff we talked about previously. An AFO is recommended if they have foot drop for fall prevention and to keep the Achilles stretched out. And then you want to usually just observe this, but obtain an EMG if no improvement is noted after 3 months to see if it warrants surgical exploration of the nerve. You want to consider late nerve decompression or muscle transfers if dorsiflexion does not return. Extensor mechanism rupture is the next complication that can occur during surgery or postoperatively traumatically. Patellar tendon rupture is rare and it is a devastating complication with an incidence of right around 1%. It's associated with previous knee surgery, a previous knee manipulation, and distal realignment procedures of the extensor mechanism like a tibial tubercle transfer. This can occur intraoperatively with avulsion from the tibial tubercle or postoperatively due to a manipulation under anesthesia that's overly aggressive. impingement or trauma, usually with a fall directly onto that knee, especially with abrupt hyperflexion that will rip the tendon or tear it off of one of its attachment sites. X-rays will show patella alta or baja, depending on if it's the quadriceps or the patellar tendon that has ruptured. Treatment is non-operative in a knee immobilizer for 6 weeks for partial tendon ruptures where the extensor mechanism and active range of motion is still intact, or in patients that are not surgical candidates. Otherwise, primary repair with or without augmentation with a graft is indicated for a complete rupture. Extensor mechanism allograft or a mesh reconstruction is indicated for chronic ruptures or irreparable ones. The extensor mechanism allograft is usually a bone block tibial tubercle with the patellar tendon, the allograft patella, and the fan of quadriceps tendon that you will then create a trough in the tibia for the bone block and fix that usually with screws and washers or wires or both. And then you'll sew the quadriceps tendon into the remaining quadriceps tendon of the patient. However, failure rates and re-rupture of this is very high. Also, one of the biggest complications with this is severe deep infection. So the complications are incredibly high, and usually the outcomes overall are very poor. And so this is used in limited patients, usually with limited medical comorbidities and a prolonged life expectancy. The mesh reconstruction involves putting a Gore-Tex mesh into a trough or tunnel in the tibia and then sutured into the remaining patellar and quadriceps tendon to provide an anchoring point for it. There are a little bit better results with this in terms of function and decreased complications compared to the extensor mechanism allograft, but even these are almost universally poor unless the patient is very healthy, very motivated, and a lot of luck happens. So usually a chronic rupture or an irreparable rupture is a severe problem fraught with complications and poor outcomes, as well as the treatments for it. And so many times the final indication here is fusion of the knee. Patella fractures can be treated non-surgically if the extensor mechanism remains intact. A revision surgery or patelectomy may be needed otherwise. And with revision at that time, you'll perform internal fixation of the fracture. Loss of active extension of 20 degrees is an indication for operative management. Quadriceps tendon rupture is rare, less than the patellar tendon, but it does exist, and again, usually due to vascular compromise of the tendon and anterior extension of the soft tissue releases at the time of surgery. Stiffness and arthrofibrosis is a very common complication following total knee replacement. Preoperative risk factors include limited range of motion to begin with, patella baja, and low pain tolerance. Most predictive determinant of postoperative range of motion is preoperative range of motion. So many times, because the tissues have scarred down and contracted, even with an excellent surgery, patients will not experience meaningful gains in range of motion. So if nothing else, counseling the patient on appropriate expectations is important. And then PCL substituting designs can help with range of motion when significant preoperative stiffness is present, just by increasing that flexion gap and space available that allow you to get a little bit more range of motion. Technical factors include overstuffing the patellofemoral joint will limit the amount of flexion the patient can then obtain because of the tightness of the extensor mechanism as it starts to wrap around the femur. Malrotation of the components will not allow for full range of motion. Tight flexion or extension gaps, so overstuffing the tibial component or unbalanced knees will significantly limit range of motion. If you elevate the joint line, that gives you relative patella baja, which will limit flexion range of motion. And then over-tightening of the extensor mechanism during closure will limit flexion as well. That's why a lot of people advocate for closing the knee in flexion. Postoperative risk factors include delayed physical therapy, presence of infection or wound complications, heterotopic ossification, severe hamstring spasm, or use of a continuous passive motion machine. This used to be routinely used for all knee replacements because of the pain and the thought that it would improve range of motion, but in reality these have actually been shown in multiple studies to decrease range of motion, and particularly to give flexion contractures after surgery without the ability to fully extend the knee. Evaluation and treatment of this is, first, you have to rule out infection as a cause. Once you have done that, you want to rule out prosthetic malposition or alignment in things like patella baja or elevation of the joint line. Non-operative treatment includes manipulation under anesthesia, and the ideal time for this is within 3 months of surgery. Some studies will say 4 months. Some studies show there's still at least some benefit out to a year, but the problem is once you get beyond about 3 months and that scar tissue is maturing, the amount of pressure and force required to perform the lysis of adhesion starts to become equivalent to the force required to either cause a supracondylar distal femur fracture, skin rupture, patellar tendon rupture, things like that. So your risks of complications go up significantly. Operative treatment would be an arthroscopic or open lysis of adhesions with a manipulation under anesthesia, especially if they've already failed an MUA or they're presenting greater than 3 months out. And then last resort is revision total knee arthroplasty, especially if there is an identifiable cause like malrotation or patella baja, or if there's no other obvious cause where you want to downsize your polyethylene to make the knee a little bit less tight and perform an open sclerectomy at that time. Patellar Clunk syndrome is a rare phenomenon only seen in posterior stabilized total knee arthroplasties because of the presence of a box cut in the femur. This is caused by a fibrous nodule that forms on the posterior surface of the quadriceps tendon above the superior pole of the patella. This becomes caught in the femoral box as the knee goes from flexion into extension. And so as the knee is in flexion, like the patient getting up from a chair, and they start to go into extension, as the knee approaches 30 to 45 degrees of flexion, that nodule will pop out of the box, creating a palpable and audible clunk. Sometimes this is painful, sometimes it's not, and it's more of just a nuisance. The cause of the formation of the scar tissue in that area is not really known. It may be the cause of direct trauma to the quadriceps tendon during patellar resection during total knee replacement. It may be repetitive microtrauma at that area on the edges of the box during range of motion. Another possible cause is impingement of the quadriceps tendon on the femoral component if the patellar component is too small. So here's a drawing of that on the right, how in flexion it gets stuck in that box, and as they go from flexion to extension it abruptly jumps out. They can have anterior knee pain. They will definitely have knee popping and catching with this particular motion, and it usually presents more than a year after surgery, after you've had enough time to build up that kind of scar tissue. Physical exam will reveal that pop or catch as the knee jumps from 40 degrees of flexion to extension. The suprapatellar fibrous nodule gets stuck in that trochlear groove box, and with further extension the fibrous nodule escapes abruptly as the tension increases. Operative treatment includes arthroscopic resection of the fibrous nodule. Arthrotomy and nodule excision are reserved for patients with recurrence after arthroscopic treatment, or in the setting of loose or malpositioned patellar components where you may need to revise those concomitantly. John Insull recommended a limited synovectomy of the posterior surface of the quadriceps tendon as a prophylactic measure for this condition whenever performing a posterior stabilized arthroplasty. Otherwise, this is largely non-existent with newer designs or when a box cut is not made. Femoral notching is placement of the femoral component so that it is not flush with the distal anterior femur on the anterior flange of the component. The prosthesis then digs into the distal femur and creates an abrupt stress visor, particularly to severe bending or rotational force. There have been basic science studies on this where they take cadaver bones and they notch, and they do find that it does significantly lessen the load to failure. There are some other studies that suggest that perhaps notching is not the risk factor that we thought, but probably the degree of notching, the host bone, and the types of injuries that patients experience all play a role in whether or not this truly represents a risk factor for fracture. You can see the images on the right where there is a severe femoral notch, and then obviously the supracondylar femur fracture at some point post-operatively there on the right. The Tay-side classification is an axial look at the femur. Grade 1 is violation of the outer table of the anterior cortex. Grade 2 is a violation of the outer and inner table of the anterior femoral cortex. Grade 3 is a violation of up to 25% of the femoral canal. And grade 4 is a violation greater than that, basically into the medullary canal. And again, these may represent progressively increasing risk for fracture. Aseptic loosening is another common late cause of failure of total knee arthroplasty, usually as a result of excessive polyethylene wear. This is usually a macrophage-induced inflammatory response resulting in bone loss, so not osteolysis directly from osteoclastic activity. The steps in the process is that particulate debris starts to form over time from wear out of the components. Macrophage-induced osteolysis then begins to occur as the macrophages try to clean up that debris. The prosthesis then is allowed to have a small amount of micromotion as its attachment to the bone gets degraded, and then finally the particulate debris gets disseminated along that whole interface between the host bone and the implant, which allows for rapid progression of this and then complete aseptic loosening with bone destruction. Presentation is that this is often painless early in the process, and it will be detected on radiographs only with a halo around the implant or around portions of the implant. Eventually, they will have localized pain around the loose components, aggravated by weight bearing and activity, with what's called the get up and go phenomenon, which is where the patient has no pain at rest. They go to get up and move, and that becomes extremely painful, but then as they continue to walk, they almost impact the prosthesis into their bone, and so the pain actually gets better. Then when they come to rest again, it sort of falls apart, and then they experience this all over again. On imaging, the x-rays will usually show radiolucency or even cyst formation around the components. You may see a change in position of components on progressive radiographs. You may also see eccentric polyethylene wear or metal on metal phenomenon where the femur has eroded all the way through the polyethylene. CT or MRI may show the particulate debris and adverse local tissue reactions. Labs are typically normal because it's not an infectious or inflammatory process. And treatment is either observation if the implant is stable, there's no symptoms, and or the patient is a poor surgical candidate. Otherwise, you have to revise the total knee, especially if there's pain or an impending frank loosening of the implant. Intraoperative fractures are very uncommon, but they do occur at around 0.5% of cases, most common in women and osteoporotic bone. The majority occur during exposure, bone preparation, and trialing of components. Computer-assisted knee arthroplasty can cause post-operative fractures due to navigational pin placement and stress risers. So this thankfully is rare, but it can be devastating when it happens, and usually requires either revision surgery or internal fixation depending on where the fracture occurs and how it occurs, as well as when. In a large review article of 18,000 total knee replacements, it showed that there were 67 intraoperative fractures. 80% of these were female. 76% of them occurred in the femur. All were cemented components. 48 out of 67 were posterior stabilized components, which again usually means a box cut with bone being taken away, which can increase the risk of fracture, especially of a femoral condyle. Adolph Lombardi found 40 fractures in 900 posterior stabilized total knee arthroplasties, and he attributed the high fracture rate to the intercondylar box cut placed excessively medially or laterally, thereby weakening the respective condyle. 14 out of 66 patients required revision of the components. In terms of other treatment, 29 received an open reduction in internal fixation, 10 were able to be managed with simple conservative measures and observation, and 16 were managed intraoperatively by conversion to stemmed components as opposed to typical resurfacing components. There's no real consensus on treatment. It's based on the surgeon, the experience, and the specific type of fracture and location. Here are some examples of some of the issues that can arise from this. So this was obviously a very complex revision knee surgery, but the image on the left is the index procedure where there was multiple fractures in the femur and the tibia during extraction of components, and this was actually the second stage of a two-stage revision, and it was from fracture in between from excessive physical therapy by the patient with the antibiotic spacer in. And so we fixed these intraoperatively with K-wires, but you can see they all started to migrate post-operatively. In the middle, that's about 6 months post-operatively, and on the right is almost 2 years post-operatively, where they're out in the frank soft tissues at that point. So you do need to be careful with the location of these and how you fix them. This is the next one, where it's very subtle, but you can see the threads of the screw in the lateral femoral condyle sticking just lateral to the anterior flange of the femur on the frontal view on the left there, and just posterior to the stem on the lateral view, and that was where the lateral condyle was knocked off during surgery, and so a 6.5 millimeter acetabular bone screw was used to reapproximate it to the femur and then cement the component to that, and the patient eventually did very well with that with no issues. This is a very subtle example of where you can go wrong on the tibial side, especially when putting in stems, and you can see the arrow sign there where there was a subtle cortical perforation and probable non-displaced tibial fracture at the time of surgery that was treated with a knee immobilizer and protected weight bearing. and you can see on the right there ultimately went on to heal uneventfully. Intraoperative bleeding is an uncommon complication but can lead to transfusion requirements. The need for transfusion and significant anemia are associated with increased complications, particularly infection, so it does behoove us to try and prevent excessive bleeding. There are higher rates of transfusion in tourniquetless knee surgery, and there are higher rates when TXA or tranexamic acid or epsilon aminocaproic acid are not used. These are both antifibrinolytic agents. They promote and stabilize clot formation. TXA is 7 to 10 times as potent as epsilon aminocaproic acid, but EAC is way cheaper by about 50-fold. TXA, typically 10 to 20 milligram per kilogram, or about 1 gram bolus for most people right before surgery, followed by a repeat bolus every 3 hours, can be done if excessive bleeding is noted or the patient is very high risk, like they have a known bleeding diathesis. Otherwise, 1 or 2 doses at cut and closure can be accomplished, and these can be IV, oral, or topical. Systematic reviews show no increase in thromboembolic events when these are used, and there are very few adverse reactions reported. However, they are contraindicated in color blindness and renal failure. Instability after total knee arthroplasty is very common. It can be acute, it can be chronic, and it can occur acutely from an injury or be present immediately after knee replacement. Acute instability and extension is usually an intraoperative injury to the MCL, occurs in up to 8% of high-risk patients, such as those that are obese, those with severe varus deformity that require a lot of releases, and those with severe flexion contracture for similar reasons. The solution is an end-to-end repair of a mid-substance laceration or a suture anchor and screw or washer attachment for avulsions off of their attachments, followed by postoperative hinge knee immobilizer to help support that while they begin weight bearing and range of motion. Otherwise, you need to revise to a constrained condylar prosthesis. Chronic instability and extension is usually imbalance in the medial and lateral ligamentous soft tissues, often from inadequate releases at the time of surgery on the constricted side in varus or valgus deformities, or if the mechanical axis was not restored to neutral and they end up putting abnormal stresses causing attritional stretch and rupture of the ligaments over time. Increased strain stretches the tissues over time. Revision is usually necessary to restore the mechanical axis and balance the medial and lateral soft tissues. Thicker polyethylene often solves balanced instability. So if they're loose medially and laterally and equally flexion and extension, all you need is a poly swap. But if it's more complex than that, then usually you need a poly swap combined with different soft tissue releases to rebalance the knee, or even a frank conversion to CCK knee replacement. Acute instability and flexion usually results from intraoperative injury to the lateral ligamentous structures, so aggressive lateral release to correct a valgus deformity, release of the popliteus tendon, or things like that. Patients will report laxity or suffer dislocation when the knee is subjected to varus force while in flexion. Close reduction and bracing is used for a single dislocation, otherwise revision of the components for multiple dislocations, especially to constrained components. Chronic instability and flexion historically is underdiagnosed because patients often don't spend much time in deep flexion, let alone with excessive strain with medial and lateral directed forces when they're in flexion. However, when they do, they present with complications other than instability like recurrent diffusions, pain, and difficulty with ascending and descending stairs and slopes. Etiology includes an undersized femoral component where basically you don't have enough posterior condylar offset, excessive posterior slope that again increases your flexion gap, or injury to the PCL if the PCL was retained. This does require revision with careful attention to balancing the flexion and extension gaps and restoring the native joint line. So usually you will have to resolve the component issue by revising the entire component. Midflexion instability results when a large distal femoral cut is made to address a preoperative flexion contracture, thereby elevating the joint line. This is also from failure to release the tight posterior capsule in a fixed flexion deformity. When posterior contracture is not addressed, the extension gap balance is determined by the posterior capsule rather than the collateral ligaments, which is what it should be. The collateral ligaments are not balanced through the range of motion, especially in mid-flexion, and so then as they stretch out over time, they become progressively more unstable. This is best prevented by addressing preoperative flexion contracture with posterior capsular release and osteophyte removal off the posterior femur and tibia while minimizing excessive distal femoral resection. Revision involves restoration of the joint line while maintaining balance, flexion, and extension gaps. So that concludes our common total knee arthroplasty complications lecture. Obviously, feel free to reach out at any time if you have any questions or issues, and I'll leave you with my Pacific Northwest Pride slide. This is an image of the large Salt Creek Falls, not far from Odell Lake and Willamette Pass Ski Resort in Central Oregon, a little bit southeast of Oak Ridge. I think more impressive than Multnomah Falls if you get the time and opportunity to head down there to sort of what is the middle of nowhere. Thanks for listening.